Good evening. Today we are going to talk about status epilepticus in children, adults, newborn, and in pregnant women. It's an important topic. There are some new addition to this topic than what we had done before based on Lancet Neurology information. As you all know, status epilepticus is a life-threatening emergency that is characterized by prolonged or recurrent seizures without recovery between episodes. Prompt treatment can prevent irreversible neuronal injury, morbidity, and mortality. There are disparities on the outcome in high-income countries versus low-income and middle-income countries. Even among low and middle-income countries, there are disparities. This is a new concept. I never knew this one. T1 and T2. T1 denotes when the seizure activity terminates. T2 means time at which long-term consequences might occur, including neuronal injury and alterations of neuronal networks or death. It's very important. It varies between type of the seizures. When the seizure needs to be terminated, at which point, at least with the current understanding, the neuronal damage and other deficits could occur. In patients with tonic-clonic seizures, the T1 is 5 minutes. The seizure needs to stop within 5 minutes. If it prolongs after 30 minutes, it will leave damage. Focal seizure with impaired awareness, it needs to stop within 10 minutes. If it lasts more than 60 minutes, it leave neurological deficit. Absence needs to stop in 10 to 15 minutes. And when will it cause neuronal damage? We do not know, as far as now we know at this point. This published in Lancet Neurology 2025. Other definitions. What is early or impending status epilepticus? Seizure lasting longer than 5 minutes without recovery of consciousness in between seizures. Second, established seizures. Seizures do not respond to treatment with first-line benzodiazepines. That means status epilepticus is established. When do you call refractory? If the seizure continue after 2 adequately doses of anti-seizure medications, meaning benzos and the second line dose, then it is called refractory. Super refractory means seizure lasting more than 24 hours. There is another group called NORC, new onset refractory status epilepticus. Then it is subset FIRES, febrile infection related epilepsy syndrome. As I said, it is a subset. The febrile infection proceeds by 24 hours to 2 weeks. Those are all rare, but it is better to be aware of it. Convulsive status epilepticus affects 9 to 40 per 100,000 people per year. Higher rates in children and adults, and the incidence is higher in low middle income countries than high income countries. The highest age specific rate is 51 per 100,000 people per year. It's found in infants younger than 1 year. So in pediatricians, private practitioner caring for children, you should need to listen to this one, and also please spread this information to those people who are caring for, especially the younger age group and also the older age group. Those are all mostly affected. Neonatal seizures we will discuss briefly later part of the seminar, and also non-convulsive status epilepticus, like focal motor seizures, non-motor seizure, absence, we are going to talk about too. So how does the status epilepticus happen? It's a failure of inhibitory pathways mediated by GABA and hyperactivity in excitatory pathways mediated by glutamate. For some reason, if that happens, that leads to status epilepticus. It leads to neuronal damage, cell death, and alterations in brain networks. The seizure lasting longer than 30 minutes represent beginning of neuronal damage with self-perpetuating dysregulation. This 30 minutes changes between the type of the seizure as we saw earlier. T2 varies whether it is convulsive tonic-clonic seizures or non-tonic-clonic seizures and absence seizures. The prolonged seizure leading to internalization of GABA A receptor is a very important concept, reducing the synaptic inhibition as well as responsiveness of benzodiazepines. It's recommended to give two adequate dosed benzos. If it doesn't work, increasing number of benzodiazepines will not help because the A subset of GABA receptors will get internalized, so they are not exposed to furthering the benzodiazepines. So it's very important. So in doing third, fourth doses simply increases adverse effects without causing suppression of seizures. Status epilepticus leads to increased epinephrine and norepinephrine levels, promoting peripheral vasoconstriction to enhance continued perfusion and oxygenation of muscles and brain. It causes cyanosis and decreased oxygen saturation. The longer the seizure continues, it increases the risk of compensatory failure, resulting in decreased perfusion, oxygenation, and glycemia, mostly hypo. The high rate of decompensation with cardiovascular collapse happens if the seizure, especially generalized tonic-clonic seizure lasting 20 to 40 minutes, that's what will happen. Differential diagnosis. One should differentiate status epilepticus from dystonia and myoclonus, and also psychogenic, so-called fake seizures. The psychogenic non-epileptic seizures will have fluctuating course, retain awareness despite bilateral convulsive activity, asynchronous movements, forced eye closure, it's very typical, lack of labored breathing postictally, and a rapid return to baseline function. Only way to differentiate these disorders by having EEG. Otherwise, it is hard to differentiate the psychogenic seizures and movement disorders from seizures per se. So what are the differentiating features from psychogenic seizures to the real seizures? One has to have an EEG, but still there are some clinical clues one can depend on. One, the dissociative seizures, or otherwise the psychogenic seizures, longer, more than 5 minutes in individual events. They will have a fluctuating course, waxing and waning, asynchronous rhythmic movements, pelvic thrusting, side to side head body movements during convulsion, closed eyes, ictal crying, recall of items during the event. Those are all very 12 point towards psychogenic seizures. And also, one should remember having a tongue biting, incontinence, gradual onset, non stereotyped, flailing and thrashing movements, opisthotonus, associated injuries does not preclude psychogenic seizures, meaning psychogenic seizures also can have all these items. Another group is called status dystonicus. So rare, potentially life-threatening condition that can be mistaken for status epilepticus. Other group is non-convulsive status epilepticus. They can present as altered mental status like hallucinations, confusion, coma. If that is undetermined, so you don't find a reason for it, you can get the EEG that will show whether it is seizure or not. Motor phenomena like automatism, ataxia, dysarthria, autonomic changes, pallor and vomiting, history of epilepsy or convulsive status epilepticus. All these can be missed if you do not have a high index of suspicion for seizures or getting EEG done to rule out. The non-convulsive status epilepticus is associated with neuronal injury and increased morbidity without clinical seizures. It's a very important point because missing them will lead to neuronal damage, especially in children. It can cause a developmental delay they need to live with. So, non-convulsive status epilepticus needs an urgent intervention with the same medications as we are going to discuss. Etiology of status epilepticus. Acute symptomatic, remote symptomatic with acute precipitant progressive encephalopathy, febrile status epilepticus, cryptogenic radiopathy. Don't worry about it. All of them we are going to treat the same way. This is for academic point of view. Knowing is important, but as far as treatment point of view, we will make it as simple as possible. Acute symptomatic, meaning associated with meningitis, encephalitis, electrolyte disturbances, sepsis, hypoxia, and intoxication. They account for 26% of status epilepticus. Remote symptomatics, that means the patient who had previous CNS injury, they account for 33%. Remote symptomatic with acute precipitant. That means they had a previous CNS injury with concurrent exacerbating factor like illness or hypoglycemia accounts for 1%. Progressive encephalopathy, especially in children with underlying progressive neurologic disorder, accounts for 3%. And febrile status epilepticus accounts for 35% of the status epilepticus cases. Cryptogenic 15%. Another group is called electroclinical syndromes. 10% of children with epilepsy will present with status epilepticus as their first seizure. So keep that in mind. But most of the time, you will end up referring them to peds neurologist. Hopefully, they will make the diagnosis early. This is the most important take home message. 25% of children with epilepsy develop status epilepticus in their lifetime. So, a patient with epilepsy, there is chance of developing status epilepticus is 25%, meaning you need to give an anticipatory guideline to the parents that it could happen, how to abort and how to treat and when to take the patient to the urgent care or emergency care promptly. How to prevent status epilepticus? This is the most important step. As a rule, if the seizure is easier to stop soon after it begins than after it has become persistent. And halting seizure earlier should mitigate adverse physiologic effects of prolonged seizures. It's important to abort seizure before it becomes status. So, what are the tools we have? Intranasal diazepam, rectal diazepam, intranasal midas, oral dissolving tablets of clonazepam, and buccal midazolam. The first three are approved drugs like intranasal diazepam, rectal diazepam, intranasal midas. They are approved to stop the seizures. Oral dissolving tablets of clonazepam and buccal midas, it is off label. I just want to let you know. The diazepam rectal, it's widely used. The dose for 2 to 5 years is zero point 0.5 per kilo, 6 to 11 years 0.3 per kilo, and more than 12 years 0.2 per kilo. Max dose is 20 milligram. Nasal spray, 0.3 milligram for ages 6 to 11, 0.2 milligram per kilo for ages more than 12. The max dose is 20 milligram. Buccal midas, off-label use. Midas nasal spray, initial dose is 5 milligram, second dose is 5 milligram, administered after 10 minutes if the patient has not responded to the initial dose of maximum 10 milligram. And as I said, clonazepam is off-label use. The dose is 0.01 to 0.02 milligram per kilo. The issues with the rescue medications. Number one, you need to teach the caregivers. The most common side effect with the rescue medications are sedation and also respiratory depression, especially if the patient is already on opioids, barbiturates, including phenobarbital or alcohol, especially for older pediatric patients, even in adult patients. And the other important thing you need to let them know when they abort the seizure with the medications, they still need to go to the urgent care, emergency, or the hospital. The reason being it can reoccur, or they may need to up the dose if they are already on sedation, or they may need the second line agent. So this is to control the seizure early on. That doesn't mean that they can go on with their life without um, without going to the medical care. So it's very important point. This is an important study done in 2012. It's called RAMPER trial, the rapid anticonvulsant medication prior to arrival. It's a randomized double-blind control study to find out which medication abort the seizure quickly when compared to intramuscular midazolam and intravenous lorazepam. There are two groups, the patient between 13 to 40 kilos, and another one is more than 40 kilos. And for 13 to 40 kilos, they used 5 milligram intramuscular midas and 2 milligram IV lorazepam. More than 40 kilos, 10 milligram intramuscular midas and 4 milligram IV lorazepam. What they found was interesting. Intramuscular midazolam aborted the seizure in 73.4% of patients versus intravenous lorazepam 63.4%. Is it because of the efficacy of the medication, or there is a delay involved in placing an IV and give the medication? And that is the truly debate. But again, it's a non-inferiority trial just to make sure intramuscular midas can be given in the prior to arriving, so that it will be easier for the EMS to do that one in the field before the patient even get to the hospital. Because as we said, aborting seizure is a very important step to prevent status epilepticus. Okay, how to treat? ABCs: adequate airway, breathing and circulation, then suctioning of secretions and vomitus, and medication for prolonged seizure, and monitoring vital signs including saturation, blood pressure, and heart rate. Early IV access. If you cannot get an IV access, get the IL, intraosseous line. Get the lab evaluations, do it immediately. Glucose, basic metabolic panel, calcium, complete blood count, and anti-seizure medication levels if appropriate. And identify the treatable causes of seizures like hypoglycemia, hyponatremia, and hypocalcemia. It's very important because those are all easily treatable and promptly they can recover. And if you have any suspicion, get the urine tox, urine metabolic, other metabolic studies, EEG. Most of the patients we will do EEG right away. Neuroimaging, antimicrobial should not avoid the test results. If you have a high index and a suspicion of CNS infection, meningitis, encephalitis, go ahead and start antibiotics. You don't have to have, at least here in the United States, you don't have to have spinal tap before you give antimicrobials. Antimicrobials needs to be given immediately, number one. Number two, the way the spinal tap cultures done recently has changed. Previously, the microbes needs to grow in the medium. Currently, they all do PCRs for all microbes. So even though the microbes doesn't grow in the culture, the PCR will detect right away. Leukocytosis could suggest underlying infectious etiology. Subtherapeutic levels of anti-seizure medication can be the cause of breakthrough status epilepticus, and of course, urine and serum toxicology if you suspect any ingestion. And what are the investigation into? Complete blood count, electrolytes, glucose, anti-seizure medication levels, serum and urine toxicology, spinal tap, neuroimaging, and electroencephalogram. This is, I took it from critical care clinics, basically adults. The pediatric and adults are very similar. The neonates and pregnant women are a little different, which we are going to discuss. The first line of within the first 5 minutes, number one, assess the airway, breathing, and circulation. Get an IV, glucose, blood glucose level. If it is low, go ahead and treat with D50 in adults, D25 or D10 in children and adults. Another thing is get the stroke scores done. If the stroke score is more than 4, and the stroke team should handle, so most likely the seizure is because of stroke related event. Okay. The first 5 minutes, once you assess simultaneously, one should give IV lorazepam 0.1 per kilo to the max of 4 milligram. Repeat within 5 minutes, another 4 milligram, 8 milligram. If you do not have an IV access, intramuscular midas, 10 milligram for the patients more than 40 kilos, 5 milligram if the weight is less than 40 kilos. So don't waste time in calculating. Just do this. That will, most of the time, it controls the seizure, the first one. The second is initial anti-seizure medication. There are five of them available. The most common drug used is IV levetiracetam. It's called Keppra, 60 per kilo, max 4.5 gram. In other words, 4.5 gram if the child or the patient is small, 60 per kilo. Second, IV fosphenytoin, 20 per kilo, max 2.5. Third, IV valproic acid, 20 to 40 milligram, max 3. IV lacosamide, 4 to 6 milligram, max 400 milligram. IV phenobarb, 20 per kilo. During this time, if the score is and the stroke score is high, CT angiogram, CT perfusion needs to be done. Antibiotics, antivirals, if you suspect any kind of infections, need to be given. So everything needs to be done within 30 minutes. If the patient is still seizing, then you need to differentiate whether the patient is responsive or unresponsive. If the patient is responsive, you need to load with second anti-seizure medication. For example, if you already given Keppra 60 per kilo, you can do next fosphenytoin. The order in which it's recommended at this point is levetiracetam first, second fosphenytoin, third valproic acid, then lacosamide and phenobarb later on. If the patient is unresponsive, at that point, you need to control the seizure with propofol, midas infusion, and ketamine. At this point, the patient needs to be intubated and possibly have heart line, central line set up too. So during this time, the patient needs to be hooked up with EEG, send anti-seizure drug level, and the patient needs to be in ICU or neurointensive care. If the patient still seizing, and discuss with intensive care attending, and most of the time at this point, I would go for Pentobarb 10 to 20 milligram plus 0.5 to 5 milligram per kg per hour. Okay, so as I informed you, we start with levetiracetam, fosphenytoin, and valproic acid. But one should remember levetiracetam because it is usually available in the floor, and you need to be careful when they have liver disease and pregnancy. Valproic acid, sorry, levetiracetam is first choice if there is a liver disease and pregnancy. Valproic acid is a first choice if they have renal disease, myoclonic status, and absence. Fosphenytoin preferred to phenytoin. Actually, here in the United States, I never used phenytoin. It's always fosphenytoin because it's less associated with hypertension. Common side effects, fosphenytoin can cause hypotension, cardiac arrhythmias, and somnolence, but I never seen one. Valproic acid can cause hyperammonemia, hepatotoxicity, thrombocytopenia, and teratogenic. So in pregnant women, valproic acid is out. And also, underlying liver disorder do not give. In children, do not give valproic acid because they may have undiagnosed metabolic disorder. Lacosamide can cause AV block, bradycardia, and hypotension. Empiric antibiotic doses, vancomycin 25 per kilo, max dose of 2.5 gram, ceftriaxone 2 gram, acyclovir 10, ampicillin 2 gram if the patient is more than 50 years or immunocompromised, and also in children less than 1 month. Does speed really matter? Yes. Age and etiology are the biggest determinants of outcomes in status epilepticus. Achieving seizure control within the first 1 to 2 hours of onset is a significant determinant of outcome. So it's very important. Abort the seizure. Number one, prevent the status epilepticus, abort the seizures, or using second line and third line medications right away. The initial medication for prolonged seizures, midas, diazepam, and lorazepam. All the three drugs can be given intravenously. Midas and diazepam have intranasal formulation. Diazepam has rectal formulation. Midas can also be given intramuscularly. All medications can be given intraosseously. So, but the preferred medication is lorazepam. This is in-hospital medication. As we already discussed in the pre-hospital, intramuscular midas works better than IV lorazepam. The intravenous preparations, lorazepam, diazepam, and clonazepam is available, and they are all pretty good in controlling the seizures. But even if you control the seizure with benzodiazepine, you need to give the second line medication to have a control for a longer time. Non-intravenously, midas, diazepam, and lorazepam is available. So when to give the second dose of medication? The first dose of benzo needs to be given within 5 minutes. If the seizure fails to stop within 5 minutes after the first benzo, the second dose of the same medications should be given. Because of the short duration of action of benzos, the second line medication is often administered even if the initial drug successfully halted the seizure. It's a very important point. So even though the benzos stop the seizure, still you need to give the second line medication. What are the second line medications? Levetiracetam, it's called Keppra here, fosphenytoin, and valproic acid. If levetiracetam fails to halt the seizure, then fosphenytoin, then valproic acid can be added. Phenobarbital is a reasonable alternative if levetiracetam, fosphenytoin, and valproic acid are unavailable or ineffective. I want to mention phenobarbital is a first-line agent in neonates. Lacosamide can be given intravenously, generally well tolerated, and there are data to support its efficacy in status epilepticus. Especially in absence status epilepticus, lacosamide has been shown to be very effective. Fosphenytoin, the dose is 20 per kilo, the max 1500 milligram. Levetiracetam 60 per kilo, max of 4.5 gram. Phenobarb 20 per kilo, max of 1 gram. Valproic acid 20 to 40 milligram per kilo, max of 3 gram. All those can be given intravenously, intraosseously. Fosphenytoin can be given intramuscularly. Don't do that, especially when you are dealing with the status epilepticus. Just stay with intravenous and intraosseous. So fosphenytoin, it's preferable if the patient is already taken phenytoin. The alternatives are contraindicated. Valproic acid, if the patient is already taken valproate, generalized epilepsy, comorbid migraine, mood disorder, the alternatives are contraindicated or previously ineffective. Levetiracetam, if the patient is already taking levetiracetam, suspected poor adherence, need for minimal drug interactions, the alternatives are contraindicated, previously ineffective. So those are the preferable way of choosing. But if you do not know anything, go with levetiracetam, fosphenytoin, and valproate in that order. I want to talk about 3 important trials done comparing phenytoin and levetiracetam. First 2 of them are in children, third one on all age groups. This is called so-called concept trial. So open label, multi-center, randomized control trial done in Australia and New Zealand. The age group they chose 3 months to 16 years. I'll tell you there is a flaw in the study too. They used 20 milligram per kilo versus 40 milligram per kilo of levetiracetam in 2 groups. We don't use phenytoin. So the issue with using phenytoin, it needs to be infused over 20 minutes. It takes a longer time to control the seizures. As we already have seen, 0 to 5 minutes. The second one is 5 to 30 minutes. So by the time you prepare and do, it takes a long time. So there is a delay. There is my suspicion. The second group is 40 milligram per kilo. They compare with we typically give 60 per kilo. I have already shown in the previous slide that is our standard protocol. So I think that is the design itself flawed, in my opinion. What they found was there was no difference between these two groups. The conclusion they came up with levetiracetam is not superior to phenytoin for second line management of the pediatric convulsive status epilepticus. It was published in 2019 Lancet. The second one is called Eclipse trial. Again, multi-center open label randomized trial from United Kingdom. The participants were aged 6 months to 18 years. They did the same thing, like levetiracetam 40 per kilo over 5 minutes, phenytoin 20 per kilo over 20 minutes. By the way, the levetiracetam can be pushed. It doesn't have to run over 5 minutes. Phenytoin, if you give, yeah, it needs to be run over 20 minutes, but here we do fast phenytoin. That is a little bit quicker we can do because the side effects are less with fast phenytoin. Anyway, as we expected, there were no difference between these two groups, so they came up with levetiracetam was not significantly superior to phenytoin. So they conclude it could be an appropriate alternate to phenytoin as a first choice, but they didn't show the levetiracetam is superior against phenytoin. Again, published in the same year, 2019. The third trial is called ESET trial. It was done in United States. It's a little different from other two trials. It is again multi-center double-blind randomized control trial. The participants 2 years to older, all the age groups were included except of course neonates and children less than 1 year. What they found and also what they did was they compared three drugs, levetiracetam, fosphenytoin, and valproate. This is what they found. In children, there was no difference between whether you give fosphenytoin, levetiracetam, and valproate. In adults, again, there is no difference between these three drugs. On the other hand, in geriatric population, valproate worked much better than fosphenytoin and levetiracetam. It's an important point. It was published in 2020, again in Lancet. The ESET trial concludes any of the three drugs can be considered as a potential first choice second line drug for benzodiazepine refractory status epilepticus. If the seizure persists, so you have given second ASDs, anti-seizure medications, second line, first dose and second dose, still the patient is seizing. Then you need to move on to continuous infusion of midas, propofol, pentobarb, or ketamine. There is no standard guidelines at that point, or there is no studies compare these four drugs. The neuroconsult needs to be done. At this point, the patient need to have continuous EEG monitoring. As I said, there is no consensus which drug is best, but I can tell what I think. The midas and pentobarb require secure airway. In my opinion, all those things, all those medications I mentioned secure the airway at this point. Midas and pentobarbital infusions can induce significant hypertension. Whenever I start pentobarb infusion, I intubate and place an outline. Not most likely, I will have fluid ready and vasopressors ready. Ketamine has a less effect on BP and does not require intubation. Propofol infusion, you should aware, especially, well, not in pediatric, both pediatric and adult patients, there is risk of propofol infusion syndrome, keep in mind. So we don't use for that purpose for long-term propofol infusion. The additional treatments one should consider, think about it, like ketogenic diet, corticosteroids, IV immunoglobulin, and vagus nerve stimulation. So, what are the difference between these drugs? Midas, favorable hemodynamic profile, but tachyphylaxis can happen. Need deposit into adipose cause prolonged sedation. In my experience, Midas has never done a good job in controlling the seizures. It's simply prolonging the time. Propofol could, but I have not used because of the fear of propofol infusion syndrome. Ketamine is really a good thought because this is the only medications work through the different mechanisms, like it works through the NMDA and favorable hemodynamic profile. I don't have humpty number of experience with the ketamine, but this is a good thought. We can put along with pentobarbital. Pentobarbital is my go-to. It does control the seizures, 100% guaranteed. That doesn't mean that it will control the seizure forever. The issue is as soon as you go down, then seizure reoccurs. That's the reason I think having ketamine and pentobarb together might help at that point. The but you should know the side effects of the pentobarb too. One is prolonged half-life, cardiac depression, so always have vasopressors on board and causes bone marrow suppression and ileus. And of course, at this point, the patient will have continuous EEG monitoring. And in adults, and if you suspect autoimmune or paraneoplastic, that panels need to be done, imaging for tumor needs to be done, adjunctive treatments need to be started at this point, immunosuppression, ketogenic diet. So often, even in the United States, it gets delayed. I think early initiation of this maneuvering can control the seizures or limit the damage from status epilepticus. Now, status epilepticus in newborn. Number one, the diagnosis itself is challenging, but we'll go one by one. When you suspect seizures, connect with video EEG. Whether the patient has just electrographic seizure only or electrographic with clinical manifestations like automatisms, clonic seizures, epileptic spasms, myoclonic, tonic, or non-motor like autonomic, pallor, um, vomiting, or BP changes, behavior arrest, sequential, unclassified. How do you treat? Very important thing in neonatal seizures, check glucose. As I said, glucose, calcium, and sodium, you need to check. That could be the cause. If that is a cause, you can treat immediately. As I mentioned earlier, the first line medication in newborn is phenobarbital 20 per kilo. If the seizure persists after 15 minutes, give second dose 10 to 20 milligram. May need ventilator at that point because at that point the patient cannot breathe on her or on his own. If the seizure persists after 30 minutes, add levetiracetam 20 per kilo. If the seizure persists after 30 minutes, give second dose. If the seizure persists after 60 minutes, give phenytoin 20 per kilo. Seizure persists, repeat dose after 30 minutes, consider pyridoxine at that point. And finally, midas infusion. So if you really look at it, they're choosing the drugs are different from pediatrics and adults. And also the dose, look at the Keppra dose, very minuscule and compared to 60 per kilo. Well, these are all we have at this point. This is the way they are operating. I think further research is needed, in my opinion. Status epilepticus in pregnancy. There are two kinds. Status epilepticus with prior history of epilepsy or new onset status epilepticus called NOSAP. The NOSAP is caused by four entities. One, posterior reversible encephalopathy syndrome, reversible cerebral vasoconstriction syndrome, eclampsia, cortical venous thrombosis. This is interesting. The literature review and protocol proposal published in 2022. If you really look at the case reports, they could go through. Most of them are case reports. Only there are two retrospective studies. Two studies. One is retrospective and another one is prospective. So what is really making me feeling bad was Significant number of patients, for example, the first one, the retrospective study, almost 30% had death. Even though it says 57% had poor outcome, this actually it's miscalculated. Same 30% of them have death in this prospective study too. So that is the significant damage that happen in pregnant women if the patient is having status epilepticus. So it's very important to treat them correctly. So it's a two groups, status epilepticus with eclampsia or status epilepticus in pregnancy outside eclampsia. Eclampsia being most common than the other group. First, we talk about eclampsia. Eclampsia give first line of treatment is mag sulfate. The loading dose is 4 gram or 6 gram over 15 to 20 minutes, followed by 2 gram per hour. This particular article says or intramuscular. I will kind of say no to that one. Give intravenous. If you don't, just go for IO because controlling seizures is very important because you are otherwise one third of the patients are going to die. The second line is like adults, lorazepam, diazepam, midas, the doses are very similar. They call third line, they go to infusions. Midas, propofol, thiopental. They use thiopental and ketamine. This is important. In these patients, especially if the eclampsia arises before 30 weeks of gestation, before BSEP score is low, then cesarean delivery is recommended. So very important to protect the baby while you are controlling, especially in eclampsia, the delivering the baby most of the time cures the eclampsia too. Status epilepticus in pregnancy outside eclampsia, they are treating similar to adults or pediatrics. The only difference is the timeline is not very strict like what we have seen in adults and children. Adults and children are very similar, no difference. The benzos they use midas, lorazepam, and diazepam, similar doses what we mentioned for adults and children. The second line, they're also similar to children and adults, levetiracetam, phenytoin, and fosphenytoin. And they do not use valproate, as you can see. And the next line is midas, propofol, thiopental, ketamine, as we discussed. And these also, they have to remember when to terminate the pregnancy, when to take the child out, cesarean section. That needs to be decided based on how control status epilepticus being controlled, how quickly. But we don't have the very concise protocol both in neonates and in pregnant women. I just want to throw in. So there was a survey done in pregnant women. So what kind of medication they use, kind of very interesting. Which second line anti-seizure medication they consider? 87% say levetiracetam, Keppra, similar to pediatrics and adults. When they were asked what is the second anti-seizure medication needed after levetiracetam, they chose lacosamide. It's pretty good. I was totally impressed with that. And 20% said fosphenytoin. The third question was, what anesthetic drip do you choose to control refractory status epilepticus in pregnancy? 60% said midas and 36% said propofol. So pretty much 96% chose either midas or propofol. This was published in 2024. So very recent thought process among obstetricians. Outcome after status epilepticus, why it is so important. Benzo treatment terminates status epilepticus in 70% of the cases. The second line medication is effective another 50% of the cases. So it tells you promptly aborting the seizure is the main core. As soon as The patient comes, give benzos, get electrolytes, and control the seizure. Two-thirds of the time or 70% of the time, you can abort this seizure becoming status epilepticus. Once you hospitalize, the death rate is 2.7 to 5.2%. This is also another long-term mortality after hospitalization. Also, you discharge, still 3.8 to 17% die. The outcome depends on the duration of the seizure and the underlying etiology. Some of the causal status epilepticus have high mortality and high morbidity, especially if the seizure comes after near drowning, sepsis, hemorrhagic shock, aspiration, and prolonged mechanical ventilation. These patients, they carry high mortality and high morbidity. Be aware of that. The refractory status epilepticus can increase mortality to 32%. That means status epilepticus lasting more than 24 hours. That means one-third of them are not going to make it. Even those who make it will have motor deficit, behavior and developmental problems, and new onset seizure. The status epilepticus itself can cause seizure. Recurrent seizure ranges from 16% to 50%. It can also lead to focal deficit, behavioral disorder, cognitive disorder. One third of the patient will develop cognitive and behavioral problems after status epilepticus. So now you know the importance of aborting the seizure becoming status epilepticus early on. Younger age at onset and duration of status epilepticus, these are the most or strongest predictors of the worst neurocognitive outcomes. So pediatricians and the practitioners who care for children and neonates, be very careful being very aggressive in controlling the seizures or reverting the electrolyte imbalance or other metabolic issues. The close monitoring of the patient's development, behavior, and cognition by both neurologist and the pediatrician after status epilepticus is essential. Take home points. Status epilepticus is a neurologic emergency. Timely intervention prevents seizures becoming status epilepticus. Check glucose, calcium, and serum sodium. Those are all easily fixable. Do not forget the diagnosis of meningitis. If you suspect meningitis, go ahead and start antibiotics right away. Suspicion alone is enough to start antibiotics. Control the seizure within 30 to 60 minutes. Neurologic consult needs to be obtained, neuroimaging in appropriate patient, and continuous EEG in all status epilepticus. This concludes the seminar on status epilepticus in adults, children, pregnant women, and newborn.